to welcome everyone to NOAHE Rounds number 8 for this academic year, session 5. And my name is Brian. I am a senior health principal economist at IHE, and I will be facilitating today's session. The Institute of Health Economics acknowledges that it's located in Treaty 6 territory, the traditional and ancestral territory of the Cree, the Dene, the Saulteaux, the Nakota Sioux, and Blackfoot. This territory is also home to the Métis settlements and the Métis Nation of Alberta, regions 2, 3, and 4. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting, whose histories, languages, and cultures continue to influence and enrich our community. We acknowledge the harms and mistakes of the past and the enduring effects of systemic racism. We dedicate ourselves to creating safe and inclusive spaces that strengthen collaboration, build respectful relationships, and engender change. Please join me today in welcoming our presenters, Dr. Jennifer Zwicker and Sean Jia. Dr. Zwicker is Director of Social Policy and Health at the School of Public Policy, Associate Professor in the Faculty of Kinesiology at the University of Calgary, and Canada Research Chair in Disability Policy for Children and Youth, and also the Chief Scientist for Kids Brain Health Network. Her research program assesses interventions and informs policies around the allocation of funding, services, and supports for youth and disabilities and their families. Dr. Jia is a research associate for the School of Public Policy at the University of Calgary. He holds a BSc in pharmacy from the University of Alberta and an MSc in health economics and management from Erasmus University Rotterdam. His research focuses on the resource use and associated costs of services in children with neurodevelopmental disorders and conducting economic evaluations on interventions for this population, including e-health programs and parent coaching. So today's topic is economic evaluations for interventions in children with neurodevelopmental disorders. What are the opportunities, challenges, and considerations? And before I start, some housekeeping details for this event. Participants will be muted throughout the webinar. If you would like to submit questions during the webinar, please use the Q&A function, and the Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. So we will hold off on questions until the end of the presentation. So thank you again for joining us today, and I will hand this over now to Dr. Zwicker and Sean.
Great, thank you so much, and thanks for that kind introduction and the opportunity to present here today. We thought that it might be nice to sort of frame this discussion with some reflections on some of the learnings we've had in doing economic evaluations, particularly related to interventions designed to support children with neurodevelopmental disabilities. I'll preface it with a lot of the work we do is really focused on sort of policy and recommendations in a policy context, and certainly the evaluations of the programs and services are like intent to be a component of that. And I think there's just a lot of room for kind of greater discussion and learning and sort of using health economics approaches in this space, given the kind of particular considerations for children with disabilities. So hopefully that's interesting and relevant to this group. So maybe we'll go to the next slide. I'm just going to present a few context slides, some background to kind of set the stage, and then I'm going to hand it over to Sean, who's going to go into more detail around some of the methodological considerations and some of the and two examples. We're kind of framing them as a bit of case studies, as examples of some of the evaluations we've done and some of the learnings we've had from those. So if we go to the next slide, we've had the opportunity to work with two national networks, with Kids Brain Health Network and Child Bright, which is a CIHR Spore network, both with a focus on children with brain-based disabilities or neurodevelopmental disabilities. And one of the unique opportunities here was often to be at the ground level when they were designing the studies and designing measures, to be able to say, hey, can you insert a resource use questionnaire and a preference-based quality of life measure. And so that was a real opportunity, because often that's kind of one of the major things that comes up, is that just on the back end trying to do an evaluation, often we don't have the data that you would look for to do an economic evaluation. So that's been a big opportunity. It of course still hasn't always panned out on the back end, but with knowing kind of how data collection has gone, but there have been some great opportunities to be working with these networks in that respect. And these networks focus largely on early identification, effective interventions, and family support programs. So just so you have an understanding of the types of work they do. And so we've been doing some cost analyses, some economic evaluations, and have really been able to work really closely with those project teams. So if we go to the next slide, the nice thing I would say is that the researchers in these teams were very receptive to working with our group, and often saw it as a real opportunity. And I think that was facilitated by the networks, kind of saying this was something that was sort of a value add. So it was an interesting model that I think worked fairly well. So I'd say that for neurodevelopmental disabilities, this is a group of conditions arising from disruptions in brain development or neurological functioning. Often, I would say disruptions or differences, kind of neurodivergence, and thinking about these are conditions that typically manifest early in childhood, although identification can range across all ages of the lifespan. And this typically manifests in a range of functional limitations, be that intellectual disability, learning, behavior, communication, motor skills. So it tends to be a very heterogeneous population. And a lot of the recognition is that there's real challenges in terms of not having appropriate measures that kind of capture some of the range of functional needs to address things like quality of life. And so the lack of sort of validated measures for much of the population is an important point that I think we'll touch on a little bit later. I'll go to the next slide. So neurodevelopmental disabilities affect about 75% of Canadian youth with disabilities. So this is it's a significant group among kind of childhood disability. Certainly, as a side note, like longitudinal data in Canada for children, but particularly children with disability, is really limited, which really challenges any sort of modeling that you can do in this space, because it's really hard to kind of understand longer term projections and outcomes. So that's something that is a real need, and I think probably is better served to do some of that work not in Canada, just because of the challenges we have with population level data in the space. But early childhood interventions are extremely important for children with disabilities. It's a human rights commitment that we have through the UN Convention of the Rights of Persons with Disabilities, and can really, evidence-based, is really significantly improve current and future outcomes. The challenge, of course, is getting access to those services, which tend to be very limited. And I think in the context and some of the reflections we have from a health economics perspective is often for children with disabilities, the perspective you might use in evaluation isn't necessarily the health system. Many of the services that you're evaluating might be sort of grounded more from sort of an educational intervention or children's service ministries, or largely out-of-pocket costs for parents. And so, it's a complex space in that regard too, in terms of thinking how you position the perspective and evaluation because of the kind of very distributed way we would design our disability support systems. And to that regard, it really depends even on the province you're in. It'll be very different. So this is just another consideration. Yeah, and I was just going to say that I think this point about access to services being limited, and this is a system where interventions often there's very long wait lists, and lots of challenges with accessing, or getting delayed or denials in support, and the parent out of pocket costs. I mean, these are things that I think doubles down on the need for making the case for the value of these interventions from kind of a public payer perspective, because there are often substantial supports across the lifespan, and kind of this case around early intervention, thinking about sort of the Heckman curve and kind of how we apply that in kind of child development, it's trying to make that same case in kind of the disability context. And, this is often one that's can resonate if you can kind of make that case with the evaluation. So just some things to think about. If we go to the next slide, I think this is over to you, Sean.
Thanks, Jen, for providing the introduction. Can you guys hear me okay? Good.
Yeah, we can.
Okay, so some things to look at on why economic evaluations in children with NDDs are important. So there's substantial economic burden from lifelong impacts on individuals, families, and communities from children with NDDs. The cost of care spanning multiple service sectors. So this includes health, education, social services, and sometimes justice systems as well. A study on the lifetime cost of supporting an individual with autism in Canada was estimated to exceed 1 million when including direct care costs and lost productivity. So it's quite clear that productivity costs for children's caregivers and the affected children themselves in adulthood can be extremely significant. Few economic evaluations have specifically focused on NDDs despite increasing valuations in pediatric health. Now moving on to methodological considerations. So I'm going to discuss these 4 components of economic evaluations and their considerations in children with NDDs. So we're going to look at perspective and time horizon, measurement of costs, measurement of outcomes, and caregiver and family effects. Starting with the perspective and time horizon, Canada's Drug Agency recommends that a publicly funded healthcare payer perspective is taken for the reference case analysis. When a broader societal perspective is of interest to the decision maker, time lost from paid and unpaid work by both patients and informal caregivers should be included in a non-reference case analysis. So the perspective sets the framework for which costs and outcomes to include in the evaluation. With regards to the time horizon, it is recommended that it is long enough to capture all relevant differences in the future costs and outcomes of interventions being compared. Looking at the application of perspective and time horizon in interventions for children with NDDs. So NDD interventions typically have impacts beyond health. So this can include the education sectors, social participation, and justice system. So we believe that adopting a societal perspective provides the scope to evaluate potential changes in these additional sectors. Costs and health effects for both patients and informal caregivers are also better captured under a broader societal perspective. Non-health costs include informal caregiving, time costs of seeking and receiving care, and the impacts on the child's future productivity in adulthood. A lifetime horizon may also be important as interventions are expected to extend beyond childhood. However, it can be challenging to model long-term costs and outcomes as the needs of children with NDDs can vary substantially over time. So now moving on to the measurement of costs. The CDA recommends to systematically identify, measure, value, and report all relevant resources based on the perspective of the publicly funded healthcare payer. So I'll be discussing the costs of care and the productivity costs in children with NDDs. So productivity costs are a significant component of the economic burden of NDDs, although outside of the scope of the public healthcare payer. So with the costs of care, NDD interventions typically affect costs in multiple care sectors, including healthcare, therapeutics, behavioral or educational services, and special needs services. The service needs of children with NDDs tend to vary and with both setting and age and are not constant. So for example, a child with autism may have a home-based special educator in early childhood, and as they enter their school years, they might require special education and employment support as they transition to adulthood. So compiling and quantifying service usage throughout a lifetime can become challenging. A narrow healthcare perspective may bias economic evaluations, as most services often occur outside the healthcare system. It is estimated that less than 10% of the economic consequences of children with NDD are in the healthcare system. Now moving on to productivity costs. So the employment impacts on primary caregivers. They often have to give up work, reduce their hours, or change positions in order to provide care for their children. It is estimated that 85% of individuals with autism will require lifelong assistance from parents or families. Mothers of children with disabilities are also less likely to work. With regards to the future productivity of children with NDDs, a lack of social skills, adequate training, and appropriate work environment and support or education can put adolescents with an NDD at huge disadvantages in obtaining and keeping employment as they transition from school to the workforce. The employment rate of working age adults with an NDD is less than a third of the rate of people without a disability. Productivity costs are typically captured as a loss of value of gross earnings. People with NDDs on average make less money than people without NDDs. While not unique to NDDs, quantifying and incorporating future productivity costs of children with NDDs require careful considerations. So under a human capital approach, interventions would be prioritized for more affluent individuals. If we exclude the impacts of early interventions on future adulthood productivity, this can underestimate the effectiveness of the intervention. Now looking at the measurement of outcomes, CDA recommends that in the reference case analysis, quality-adjusted life years or QALYs should be used to capture the value of the effect of an intervention. Health preferences should reflect the general Canadian population. Very few interventions in children with NDDs have reported QALYs due to challenges in measurement. Broadly speaking, deriving a QALY in the pediatric population can be difficult. A review of pediatric economic evaluation found only approximately 25% were cost utility analysis and about 65% were cost effectiveness analysis. Primary outcomes of NDD intervention studies commonly have clinical or disease-specific outcomes or general health profile measures familiar to clinicians or patients. For example, a cost-effectiveness analysis on communication-focused therapy for preschool children with autism used autism symptom severity as the primary outcome. With a measure like this, we do not know the societal value of a unit improvement in the outcome, so it becomes challenging to even compare interventions within the NDD space due to a lack of standardization of outcome measures. Diving deeper into outcomes. So many general health profile measures are not specifically designed for children with NDDs. General health profile measures also may have different domains, with some focusing on social well-being and others focusing on physical and emotional well-being. Mapping algorithms to utilities for the NDD population from general health profiles are not available. The Pediatric Quality of Life Inventory is a general health profile that has been used in children with a wide range of NDDs. With regards to preference-based measures, few studies have incorporated preference-based measures. The validity and reliability of measures in children with NDDs needs to be examined. The Health Utilities Index 3 has been found to be sensitive to clinical measures used for children with autism. Another approach to potentially obtain qualities would be direct approaches, such as the standard gamble or the time trade-off. We have to note that NDD impairments can limit a child's understanding of health or well-being and the concept of time, which would be necessary to allow them to indicate their preference. Now looking at caregiver and family effects. Caregiver and family effects have often been referred to as spillover effects. So essentially, this covers the impacts of a child's health on the quality of life and economic well-being of the caregiver, family members, and other relatives in the same household. Several guidelines, including the CDA and NICE in the UK, have recommended including spillover effects either in reference or non-reference cases in economic evaluation. However, the integration of spillover effects in evaluations in the NDD space has been rather limited. Parents of children with NDDs also report poorer physical and mental health and higher levels of stress than parents of neurotypical children. More broadly speaking, problematic family functioning is a concern, as it is also noted that siblings of children with chronic conditions have also been shown to have fewer peer activities and lower developmental cognitive scores. Now I'm going to move on and look at two studies that we have worked on, starting with Better Nights, Better Days. So Better Nights, Better Days for children with NDDs is an internet-based e-health intervention that provided parents with knowledge on healthy sleep practices and behavioral intervention information to implement for their children's insomnia. Children's insomnia can also be detrimental to the well-being of parents and their productivity. Behavioral interventions are recommended as first-line therapy for insomnia in children. These behavioral interventions are typically administered by psychologists in person or through multiple clinic visits, which raises accessibility and cost concerns as psychologist services are typically beyond the public payer's scope. Pharmacotherapy is considered second line if behavioral therapies are ineffective or unfeasible. If effective, the e-health delivery of BMBD can potentially fill gaps in insomnia care from accessibility and cost barriers. Now looking at the BMBD NDD study design. So it was an RCT comparing BMBD and usual care to usual care. So that meant that the parents were allowed to seek available interventions for their child's insomnia while completing the BMBD program. The targeted population were children aged 4 to 12 years with ADHD, autism, cerebral palsy, or fetal alcohol spectrum disorder. The primary outcome in the study was a sleep measure called the Disorders of Initiating and Maintaining Sleep score. Secondary outcomes included the Pediatric Quality of Life Inventory and 2 parental measures, so the single item fatigue impact score and the depression, anxiety, and stress scales. Study length was 8 months. So with the economic evaluation we conducted, we took a family payer perspective as the BMBD program was planned as a direct-to-user commercial product. So the families essentially would purchase the program out of pocket directly from the developers. The BMBD program developers did cite interest in potentially pursuing public funding or coverage in the future. We used a time horizon of 8 months, which aligned with the RCT length. So looking at the measurement of costs, the cost data was collected in the treatment utilization questionnaire under this one question, asking overall, how much did it cost for any health professional or provider's help for your child's sleep problem? This was the only question in the questionnaire that specifically addressed costs. With regards to the intervention cost, it was hypothetically set based on the developer's previous market research. In this pie chart, it shows the percentage of sample that reported zero and non-zero out-of-pocket expenses when excluding the hypothetical intervention cost. As you can see, the majority of the sample reported no out-of-pocket expenses, which may suggest a lack of access to behavioral therapies. We use non-parametric bootstrapping to address the skew in costs. Now looking at the outcomes, we used the parent proxy report of the PedsQL as the primary outcome. We also mapped the PedsQL score to the Child Health Utility Instrument to estimate QALYs. The mapping algorithm was developed in children aged 0 to 16 with chronic conditions in the United Kingdom. Unfortunately, there are no mapping algorithms for the PedsQL in the Canadian population or the NDD population. Now looking at the BMBD evaluation findings and some reflections. So the BMBD intervention group had higher average PedsQL total score improvements and higher average family payer costs relative to the control. It was estimated that the intervention had greater than 50% probability of being cost-effective when a reduction of 25% was applied on the base case intervention cost. The economic evaluation was not initially considered in the RCT design for this study. This was a consistent trend when we collaborated with NDD intervention teams that had already completed their data collection. The generalizability of the mapping algorithm to the Canadian NDD population is uncertain. The application of QALYs to the family payer is probably not that meaningful, but since the program developers indicated an interest in potentially pursuing public funding, we thought QALYs might be a good secondary analysis. With regards to the cost data, there was no systematic collection of public payer costs related to insomnia. The study focused on looking at the types of services accessed, but not the volume of services. And as I mentioned previously, it was limited to one question in the treatment utilization question. Now moving on to the second study, it's called Bright Coaching. So Bright Coaching provided parents of children with emerging developmental disabilities with coaching sessions over 6 months. So typically, the parent had 2 coaching sessions per month. The coaching program was based on 3 pillars: talk with a trained coach while waiting for their child's services or care. The coaches typically had backgrounds in healthcare or child education. Learn how to support their child and promote child development. And share, which involved connecting with other Canadian parents via the online community where they can share experiences and knowledge. The Bright Coaching RCT compared Bright Coaching and usual care to usual care in 4 Canadian provinces. So similar to the Better Nights, Better Days study, families were allowed to continue to seek locally available care while they were in the intervention. The targeted population were families of children aged 1.5 to 4.5 years with emerging developmental disabilities, either awaiting developmental services or assessments. The primary outcome in the study was the Family Empowerment Scale. So this measure has been validated for families with children with emotional disabilities. It asks caregivers questions on attitudes, behaviors, their involvement in the family, and as well as the larger community. Secondary outcomes included the parent's sense of competence scale, parental stress index, and the 36-item short form health survey, which is a quality of life measure. The study length was 12 months. We noted that there were no children measures collected, despite the intervention benefits to largely fall on the children. So we completed two cost analysis for this study. We compared the resource utilization and costs between the intervention and control groups. We also looked at potential differences in costs between provinces, types and volume of services thought for their children during the waitlist period. So in the first analysis, we took a family payer perspective. In the second analysis, we took a public payer and also a societal perspective. For the public payer, we looked at service use and costs across all sectors in health and beyond. And then for the societal perspective, we included informal caregiving costs. For the time horizon, we took 12 months, which aligned with the RCT study length. So looking at the measurement of costs, the cost data was captured in the resource use questionnaire. The RUQ is a measure that captured multi-sector service use that's been validated in children with NDDs. It is interviewer administered. It collected children's and parents' service utilization. With regards to the parents, it was specific to services that they thought to cope with their children's emerging delays. The recall period of the questionnaire in the study were either 4 or 8 months. It also captured caregiving time and household monetary income loss. Diving a bit deeper in the RUQ, so for the children's service utilization, it captured community services such as speech therapy, occupational therapy, and physiotherapy. And then additional health professional services that covered public healthcare services such as physicians, specialists, lab tests, as well as privately funded services such as psychologists, naturopath, dentists. In addition to that, medications, child-focused recreational activities, special products or materials such as toys and sensory devices were also captured. With regards to the parents' service utilization, it captures service use in physician visits, psychologists, social workers, support groups, medications, and other services. As you can see, the RUQ is a very comprehensive collection of service use and the volume and associated costs. So now looking at the cost analysis findings and reflections. So the intervention group had higher estimated costs than the control groups from all payer perspectives. This is possibly attributed to caregivers being more aware of services that can benefit their children from the coaching. Intensive early childhood interventions for children with developmental delays have been found to significantly improve future outcomes. We noted that recall bias is a concern with the extended recall periods of 4 and 8 months, so that included the reported costs as well as the frequency of services. It was interesting that the study did not include any children's outcomes when the children are expected to benefit the most from the intervention. So this can make it difficult for decision makers to compare the value of the program relative to other NDD interventions. Once again, also with the family empowerment scale being the primary measure, it's difficult to put a societal value to a unit improvement in the scale. Now I'm just going to summarize some key points. The public payer perspective may not adequately capture the breadth of services and costs impacted by NDD interventions. Also, the long-term costs and outcomes can be difficult to model or estimate due to the evolving needs of children with NDDs. Few studies have used QALYs as an outcome measure in interventions. There is a need to develop instruments to obtain QALYs for this population. With regards to spillover effects, they're substantial in the NDD population, and their incorporation into NDD evaluations needs to be prioritized. Thank you. Now we're happy to take any questions.
Hey, thank you very much, Sean. Great presentation from both you and Dr. Zwicker. So I'd like to encourage everyone who may have any questions that they thought of during the duration of the presentation to please put it in the Q&A chat box. Either one will be monitoring both. And while they wait, I guess I'll start off with the first question. So I'm glad that you presented two studies, and what I noticed, what was very stark, was the amount of data that was cost-related data that was collected between the two studies. One had very little, one had one question, literally, and the other one was more comprehensive. And I was curious what led to one having just one question versus another one using a measure that can give them a more complex perspective of the cost utilization.
Yeah, I can answer that. I mean, we worked with the Bright Coaching study before they got started and got them to use the resource use questionnaire in their data collection, kind of when they were getting going. It ended up being a measure that they became quite interested in as well, but it wasn't something they were originally planning on collecting. Whereas the Better Nights, Better Days had already started their study before we got involved, so there was kind of not an opportunity to change questions at that point. So I think it just speaks to how important that can be when you're working on economic evaluations. But it's also challenging because this took, I don't know how many years ago now. It was a number of years ago that we kind of started working with Bright Coaching, and so the time in terms of kind of following a study from when it's first started, and then there's this kind of quite a long period of you're not actually doing a lot with the team, and then on the back end, once data's collected, kind of doing a lot of the data cleaning and analysis. So it's an interesting issue for researchers who are working on health economics and economic evaluations, because it, practically speaking, kind of has this, like, it's really important to be involved up front, but then often there's quite a lag time when you're kind of getting involved again, which probably many folks on this call know, but I think it just bears saying. But I just would say there's a lot of value in kind of those conversations you can get in early and start suggesting measures in the study design.
And it's almost like a bimodal distribution of activity that goes on at the beginning and usually at the end, right?
Yeah, and I mean, I also say, like, we did this with a number of studies, and sometimes the data collection at the end wasn't to the point where you could do much on the evaluation side of things. So that's the other challenge. Like, there's a lot of factors, especially because this spanned the pandemic, that kind of had implications. But yeah, I think it is very important.
I see. So after your discussions with the research team for the first study, Better Days and Better Nights, was there like not a sense of regret, but missed opportunity? Did they feel like, oh, we should have consulted you earlier, or was it after the experience and like, oh, okay? And
well,
yeah.
I think the thing that probably could have been better illuminated was this, like, the issue that Sean raised around many reported not having out-of-pocket costs specifically for the intervention, which was interesting. But I like the assumption, and we couldn't substantiate with data, but from talking to investigators who work in the space, is largely because they were kind of getting access to nothing. So this is like another interesting challenge in the space, where usually we're comparing to standard care with the assumption that you're getting access to standard care. But the reality was that many, especially they were based in Nova Scotia, like, there was a particular shortage of access to the providers that provided kind of the standard care for sleep interventions. And so the lead investigator's assumption was that many families just weren't getting any support at all. And so this, again, made an interesting challenge for an evaluation when you were trying to compare to standard care, but then, like, actually they weren't getting the support. So that was, it would have been nice to collect more data on that. And that's where I think something like the resource use questionnaire could have better illuminated that.
I see. So then for the that brings me to the next question I had. So then usual care then for the Better Days, Better Nights was what they actually did receive as usual care, including the lack of access to services, or did everyone receive an intervention of some sort that would be considered good quality usual care in that population?
Yeah, so their design was just sort of families could seek the care that they could get access to, but it was, I think, could be very variable. And so that was kind of the way they designed the study. I think they didn't have the means to kind of provide access to standard care. So that was kind of how they had designed it.
I see. Yeah. So just a reminder to anyone who may have questions, don't be shy. You can put your questions in the Q&A. I have lots of questions myself, but I don't like to dominate the whole conversation. So happy to take any questions that you may have. Yeah,
It looks
another
like
question. Yeah,
it looks like one question's in the Q&A around the resource use questionnaire on Bright Coaching. I think that it's basically what we used was the resource use questionnaire. It was developed by Wendy Ungar's group, and there's some publications on it that we can probably put in the chat if helpful. But it's a really comprehensive questionnaire, and we were surprised to get quite a bit of, like, the data quality was quite high generally, largely because we tried to do an interview administered. So I think that was the big caveat that's important, is we've also done parent report for the resource use questionnaire, and the data quality is usually very low. So that's sort of an important consideration for study design whenever possible. Again, probably not revolutionary to people, but like these are some of the pieces that were some of the learnings that we've had from kind of working on some of these evaluations. And hopefully also the messaging from this presentation isn't like, oh, don't do economic evaluations related to children with neurodevelopmental disabilities. I think what we're trying to illuminate is that it's super important. There's lots of value in this space. And I mean, there's lots of room for innovation and methodology and approaches. So it's really, I think, a wide open space if people are interested in engaging more.
Yeah, and I think the discussion probably is even broader than just people who do health economics, right? Including people who do quality of life interventions, or quality of life measures, and validation of scales and disease measures, but pretty much everyone, quite more than just the health economists.
Yeah, for sure. Yeah, there's interesting work going on around sort of trying to validate some of the quality of life measures with using like picture-based kind of tools, and trying to make them more accessible. So I think that's a really interesting direction. And then on the other side, just policy-related implications, like especially for cost analysis and kind of the balance between out-of-pocket costs and like what is publicly provided, and also just balancing other ministries and kind of how you think about kind of multi-ministry engagement in a public payer perspective. You know, there's lots of interesting kind of things to think about outside of probably the more traditional evaluation that gets done.
Yeah. Oh, and we have another question here. Let's see, another question was curious about whether you have worked with policy decision makers in your studies in this area and how your findings have been received.
Yeah, so I think we haven't yet for these two studies because they're still going through the publication process, but we have in the past with some other evaluation studies. And I would say typically the findings are very well received because and of great interest, because there's usually, this is not the type of analysis that gets conducted in this space. I think fundamentally in the child health and disability space, there sort of tends to be this assumption that like, we don't need to do these analyses because we invest in children and care about children in a policy perspective. And, I think trying to challenge those assumptions a little bit, because there's often a real aversion to additional investments in disability support programs just because of the concerns around cost is often the reasoning that's stated. So, budget allocations on wait lists and things like that. So, it does become very important to be able to illustrate sort of the impact of these interventions. I think the thing that tends to be really missing, and the thing that everybody wants to talk about, is the sort of the return on investment sort of in the long run. Talking about the role of early intervention and investing early and how that could have impacts. So some of that kind of thinking in a modeling context. And I don't know, love to chat more with people about how to do that in this space, because it's the data is so limited and it makes it really challenging. So I think that's the big gap that decision makers do also want to talk about, because I think that's a challenge for decision makers, is often the time horizon for impact, and sort of that return can be harder when you're not necessarily seeing the immediate implications for children. And often the interventions, like you saw, are actually increasing access and uptake of public services, which isn't necessarily an easy message to sell, because that creates more cost. But it's this idea of, early access, appropriate, timely access to supports in the long run is helpful for improving outcomes for children. So yeah, I think these evaluations and the findings can be very helpful in trying to put more concrete numbers behind some of what we know from the literature, and these statements, like translating what we know from literature into sort of policy and decision maker kind of context. Resource allocation decisions.
Definitely, your point is, it definitely highlights the importance of a longer time frame, because there may be immediate higher costs because they've identified a need for the services earlier. But like you said, the downstream savings or the downstream benefits may be missed if you don't have a long enough time frame. Yeah, it's definitely challenging. One other point that one other additional challenge to all this that I've heard, trying to remember the names of the speakers, but their area of research was on transitions. So when children transition to adulthood and how their services change, because services provided for children don't necessarily smoothly transition to adulthood, and so sometimes they lose out on certain services depending on their financial situation, but also where they may be located. So an additional hurdle to doing a long-term time horizon that surpasses the pediatric time period.
Yeah.
Excellent. So I was wondering if there are any more questions from the audience.
It looks like there's one more in the Q&A around capturing long-term outcomes and costs and the broader impacts for caregivers and families, and just how to do that. I think it's a great question. I think it's probably a bigger conversation than we can address in one response. But I think one of the big challenges in Canada is just quite simply not having population level longitudinal data related to children. This makes it harder to sort of inform any model that you're developing. Administrative data sometimes can be helpful, but it's sort of limited in terms of particularly measures related to, like, individual measures for kind of child outcomes and family outcomes. So yeah, I think this is one of the big pieces that's challenging, and I think there's probably more opportunity to try to draw in data from other countries to try to inform some of those models, because I think it's the piece that it's trying to make that case around sort of the return on investment of early intervention, which is just a hard thing for us to do in a Canadian context. And there's other studies, designs that, do that, have done that in the US, and it's largely drawing off of kind of more longitudinal data sets. So I think any opportunity to find data sets that you can leverage even outside the Canadian context, I think could be of great value. So encourage to look in that space.
Mm-hmm. Yeah, it definitely harkens back to a few months ago when we had Petros Peklovanoglu from Hospital Kids talk about the data sets from Statistics Canada and the potential in that as well. So there are some data sets even in Canada. It's just being able to link them all and being able to really analyze them. It's a huge need.
Mm-hmm. Absolutely. Yeah. Sean, is there anything you wanted to add to that?
Just with the time horizon, I recall that when we were working with the Better Day studies, when I included in as a limitation, it was like the relatively short time horizon that we had taken from analysis. But the principal investigator mentioned to us that 8 months in the sleep field is actually very long for it to capture outcomes and follow up in that space. So it was quite interesting to see that.
Interesting. Yeah. Interesting. Okay. If there are no further questions, I'd like to thank Dr. Zwicker and Sean for their presentation today. And just a reminder that the next seminar will be, we are expecting Dr. Francescuti to present to us on April 16th, 2025. Please visit our website at noah.ca to register for this upcoming session. And also, if you like to be subscribed to our mailing list or get updates for all upcoming events and opportunities. Again, I'd like to thank our two speakers for a wonderful talk today. And I'd like to thank everyone for attending as well. Okay, thank you both for coming.
Thanks for having us.